Good afternoon, everyone. It's John Snyder here for Newton-Wellesley Medical Group Lunch and Learn. Today, we are excited to invite Dr. Ko to talk to us about eye surgery, cataract and corneal surgeries. I had a preview of this lecture and lots of cool video and stuff, so we're excited. We also want to make sure folks know that this is our last Lunch and Learn before our summer break. Just like your high schoolers, we like to take summer off as well. And we'll be back in September. Before I move to this slide, we want to make sure you know that all of our lectures are up on the intranet as well as YouTube. And you can search them at YouTube by searching Newton-Wellesley Medical Group Lunch and Learn, as well as on the intranet and in our intranet Newton. Next slide, please. Couple of quick announcements before we get started. We still have our free on-site and virtual fitness training for individuals and groups. It's an online coaching physical training for individuals and groups for physicians and APPs. This is free to you. We are paying it through our grant, and we want you to give it a try. You can definitely get some online coaching. Daniel's team, we'll be happy to set you up. Please email him. Also, we want to remind folks through the summer that the Shipley Fitness Center is free with badge access. So come check out our facility. The hours are great. The location is great. And if you're on campus, certainly it is a great way to get your day started or end your day before you go home. Next slide. Our physician concierge service is still going through November 2022. People who have listened to this talk before have heard me go on and on about how great this service is. This is a great place for you to get some access to find out where you need any kind of personal services, such as who's going to mow your lawn, who's going to shovel your driveway, who's going to make sure your teenager doesn't have a party while you're up at the beach house. All those things are available. Please go ahead and email the physician. You can log on by going to community.circles.com and using NWH. It's +1 access, so your spouse or partner can also have access to this. Personally, we've used this for work in our house and all sorts of other things. So it's a very unique service that's there for you for free. And they actually vet everybody that they talk to. They'll make appointments for you. And they'll also give you their thoughts about who you should start with. So anything from picking the right gift to house services. Next slide. We want to also make folks aware of our Pay It Forward program. This comes out of our wellness grant. The Pay It Forward program, the way it works is if you have a patient that one of your colleagues has gone up and above what they normally should, above and beyond contribution, it allows you to acknowledge them. And with that acknowledgement, if you send Kathy Servan a note that describes what they have done, we will then forward your note in fancy personalized script writing with a $100 gift card. At that point, that physician will then be encouraged to pay it forward to another peer, someone who's taking care of one of their patients in a way that went above and beyond. And therefore, we continue the chain of paying it forward. We have these gift cards. They're sitting in a drawer. We want to get them into your wallets. So please go ahead and participate in this program. Next slide. Before I give up the mic, since this is our last Lunch and Learn before the summer, I just want to take a second to thank 3 people who make this series possible. I know you only get to see me talking about the series, but Audrey Bossy and her team who gets these programs and these speakers aligned, and also helps me figure out who's going to talk when and get in order. And then on Audrey's team, Jane Hayward, who helps us collect our slides. All those awesome introductory slides are her doing. And of course, the great Holly Marcoux, who's always in the background as the co-host, making sure there are no technical difficulties. So thanks to you 3 for making this series happen. And this will be our last talk again until the summer. And I'll turn it over to Dr. Ko. Thanks.
Thank you, John. And thank you for having me for the last launch talk of the first half of the year. My name is Nari Ko, and I've been at Portnoy Eye Care for the last 6 months. I was at Tufts previously. And I'm going to talk to you a little bit about cataract and cornea surgery, which are my specialties that I'm focusing on at Portnoy Eye Care, and a little bit about LASIK as well. Our office is located at 1 Washington Street, not too far from Newton-Wellesley Hospital. We have a satellite office in Waltham where we staff about 1 day a week. We have 2 MDs and 2 optometrists in our practice, and between the 4 of us, we cover cataract and cornea surgeries, LASIK, glaucoma, and macular degeneration management, and just annual routine eye exams, contact lens service, and same-day urgent care. I'll just talk about the cataract and cornea surgeries and LASIK. So let's start off with cataract. And when patients present with cataract, they always ask me, what is a cataract? So when you're born with a clear lens. That's a biconvex structure in the front part of the eye. It's right behind the iris, and it's one of the 3 structures in our eye that refracts light. So for you to see an image, light needs to go through the pupil, it needs to bend, and then it needs to focus on the fovea. First, it bends at the tear film. Tear film, a healthy tear film, is actually responsible for 2/3 of the refracting power, and that's why patients with severe dry eyes often complain of blurry vision or fluctuating vision. And then it refracts through the cornea and then the lens. And as you get older, the lens proteins they denature and become cloudy and cause the light to scatter, and that's the cataract. Age-related cataract is the most common type. There are other types, for example, steroid-induced cataract, congenital cataract, or radiation-induced cataract. There are several different types. And it's very common. According to National Eye Institute data in 2010, there were about 24 million patients with cataract. That number is going to more than double by 2050. And in 2017, there are about close to 4 million cataract surgeries that were performed in the United States. That number will also rise, obviously, because the population is aging, and also patients are better educated about cataract surgery, and the technology has really improved that the outcomes are excellent. Cataract can cause cloudy vision, decreased contrast sensitivity, halos and glare, frequent change in glasses prescription, and monocular diplopia. The benefits of cataract surgery has been well established. It decreases mortality risk, decreases the risk of hip fracture, and the risk of car accidents. Just gonna mention this study because this study got a lot of press in the beginning of the year, looking at the association between the cataract extraction and the risk of development of dementia. This study was done in the state of Washington using the cohort population group the enrollment started in 1990s. They enrolled randomly selected patients from Kaiser, mostly healthy individuals, and then they were enrolled and followed up until the development of dementia. When they looked at this cohort, they found about 3,000 patients who were diagnosed with cataract before the onset of dementia. They excluded the patients who had cataract surgery before enrolling in the study. A little less than half of the patients had cataract surgery and the rest hadn't. And they actually showed that the cataract extraction was significantly associated with a lower adjusted hazard ratio for dementia, which makes sense. I think the visual input and also hearing are very important as you get older and for our neurologic function. So when a patient has cataract and they need cataract surgery, then they come in for a preoperative evaluation in our clinic. The reason typically the appointment lasts at least an hour. The reason it takes so long is because we have to get a very accurate measurement of the dimension of the eyeball. At the time of the cataract surgery, you are taking the cataract out and replacing it with a lens implant. It's kind of like putting glasses prescription inside the eye. To get an accurate measurement of the estimate of the power of the lens implant, you want to get very accurate measurements of the eye. In particular, you need a good measurement of the axial length of the eye. So that's the length of the eye from the cornea to the retina. And you also need a good measurement of the corneal curvature. Even a tiny error in axial length, even as small as 0.3 millimeter, can actually affect the outcomes of the surgery quite a bit. And once you have all the data, then you are ready for cataract surgery. Cataract surgery typically is about 10 to 15 minutes for a healthy patient. it's done under topical anesthesia with a little bit of IV sedation, usually just 5 milligrams of Versed. And the topical anesthesia is done with just proparacaine, which is a topical anesthetic that we use in clinic when we check eye pressure. And it's just a video of a routine cataract surgery. You start with making a very tiny incision in the cornea. It's about 2.4 millimeter. And the cataract is wrapped around the fibrous capsule. So you have to create a circular opening to access the cataract. It's very important that it's a circle, not like a square, for example. And then to remove the cataract, you are using this probe that's very sharp and it emits ultrasound energy to break the cataract into smaller pieces. And as you after you take the cataract out, then you are gonna polish the fibrous capsule that's going to hold the lens implant to remove as much lens epithelial cells as possible. And the lens implant goes in folded through that 2.4 millimeter incision. And in warm body temperature, the lens will just unfold. And then once unfolded, it's well centered. Then the incision is so small that you can just hydrate it to close. You don't need any suture. Now, patients who are on Flomax, they usually take a little bit longer than 10 minutes for cataract surgery. The reason is that the Flomax is an alpha antagonist. It's used as a treatment for BPH because it relaxes the bladder neck muscle. And inadvertently, it also relaxes the iris dilator muscle. And it causes what's called floppy iris. What that means is, one, the iris does not dilate, so the pupil remains small. And two, instead of maintaining very straight, tight and taut configuration, it acts more like a trampoline and it kind of moves up and down. So you just have to take a little extra time making sure that you're not damaging the iris during the surgery. And it's not, the risk of floppy iris is not just with Flomax. You can get the same effect from terazosin, alphazosin, doxazosin. Any of the zosins that are alpha antagonists can do this. And even 2-week use of Flomax can cause floppy iris. So unless the patient just recently started the medication, I don't recommend stopping it because the effect is permanent, makes no difference in terms of the surgery. But no worries, we can always mechanically expand the pupil, in this case, I'm just using what's called iris hooks to basically, instead of having a circular pupil, I'm making it sort of a rectangle to have a better access to the cataract. In this case, this patient is not only on Flomax, but he also has a white cataract, and I really don't recommend waiting this long to have the cataract surgery. Another type of cataract that can cause poor pupillary dilation is actually uveitic cataract. So for example, patients with HLA-B27 are at risk of not just ankylosing spondylitis, but they can also have anterior uveitis. When you have a chronic anterior uveitis, you have a constant inflammation that causes scarring of the iris onto the lens capsule. And so no matter how much dilating drops you use, it's just not going to dilate. So you have to mechanically expand the pupil. Once the cataract is out, then you're ready to put a lens implant in. The basic configuration of the lens implant is fairly similar between different models. The lens implant typically consists of a central optic, which is about 6 millimeter. So that's going to be where your visual axis is. And then it's supported by 2 arms of haptics that supports the optic in the capsular bag, in the fibrous capsule. The most common lens implant that people choose is called a monofocal lens. Means it only has one focal point. So you can decide to be free of glasses for driving, which means you have to wear reading glasses, or you can choose to be free of reading glasses, so you can read up close without glasses, but you're gonna need glasses for driving. You can't have both. If you have astigmatism, we have great choice of toric lenses for correcting the astigmatism. Astigmatism is a vector, so it has a directionality. So the lens, toric lens, comes with these markers, toric markers, that need to be aligned at the axis of the astigmatism. If you want to decrease your dependence on glasses in general and have a wider range of vision, then you have the option of multifocal lens. The difference here is that the multifocal lens has several concentric circles etched onto the optic. And what that does is it splits light and gives you multiple focal points. So that is an option that's available. And nowadays, femtosecond laser has been really a great addition to cataract surgery because it actually helps me in many cases, but especially in two clinical scenarios. One is when patients have astigmatism that is not large enough for the toric lens, but still visually significant. The toric lenses that are approved, that are FDA approved in the US, you have to have like a certain amount, at least there's a minimum amount of astigmatism that you have to qualify for that. But plenty of patients have less than that, that amount of astigmatism that is still affecting vision. So with the laser, you can correct that. And the second option is second clinical scenario is when patients have a very dense cataract. Some patients, like to wait until they almost go blind. The problem is with those dense cataracts is that with the phaco emulsification technique, it produces, so it uses ultrasound to break the cataract and it produces heat. The byproduct of that heat damages the cornea and causes a lot of inflammation, and it can prolong the recovery. So you have to wait for the cornea to clear for the vision to improve. Whereas if you use a laser, the laser can actually, just with the laser, it doesn't produce really very minimal heat. You can just automatically soften the cataract, and then you go in with the phaco emulsification probe, but you just use a lot less energy to take it out. The post-operative course is fairly simple. A lot of patients are on 3 eye drops, so they need to be on a topical steroid, antibiotic, and a non-steroidal. But there are lots of patients out there who really don't want to use 3 eye drops. Just recently, I had a patient who was recently diagnosed with Parkinson's and she has a hand tremor. There are patients who have arthritis or patients who with dementia are just not going to remember using 3 eye drops. For those patients, there is an option of using a combination drop. Insurance does not cover this, but it's only about $50 to $60 a bottle. You only need 1 bottle per eye and it works great. In terms of activity restrictions, I tell patients no lifting more than a gallon of milk for a week and no swimming for 2 weeks. So that was a little overview about cataract surgery, and I'm going to switch gears to talking about cornea. And my passion is actually cornea and cornea transplants. Cornea is the only part of the eye that is replaceable. You're all familiar with some types of corneal diseases like corneal abrasion. That is a common reason why patients present to urgent care, because they have a lot of pain. They have a lot of pain that because cornea has the highest density of sensory nerve, which is a trigeminal nerve. So if you have a missing epithelium that exposes the corneal nerves to air, to light, and so they're in a lot of pain. Fortunately, our eye, right at the junction of the cornea and the sclera, it's called limbus, we have stem cells that provide dividing epithelial cells. So that's why corneal abrasion heals on its own in a few days. This is just a picture of anterior basement membrane dystrophy, another disease that's commonly seen. It's more common in older patients, and you just it's just a disease where over time the epithelium just becomes irregular, usually not really visually significant, but it needs to be dealt with before cataract surgery. Unlike epithelium, cornea endothelium behaves very differently. First of all, there are no stem cells for endothelium. So once you lose it, that's it. It's not replaceable, naturally. The endothelium is important because it has active transport in a system where it keeps water out of the corneal stroma. It keeps the cornea clear by keeping it dry. But if you have trauma to the endothelium, for example, like any kind of eye surgery can do that, glaucoma surgery is notorious for causing corneal swelling. And if it doesn't get better with just medical treatment, the only option is actually corneal transplant. But nowadays, the technique for corneal transplant has really made huge advance that we can actually do, endothelial keratoplasty in 30 minutes under topical anesthesia, just like cataract surgery. So this is a video of one of my cases. And the idea is to remove the diseased endothelial cells. You're scraping it, and you deliver the corneal tissue that has the endothelial cells that's scrolled into the eye. It's a very thin tissue because the endothelial cell layer and the descemet layer right next to it are very thin. Once it's in, you can't manipulate using an instrument to unfold it because then you're going to tear the tissue. So what you have to do is you're tapping on the outside of the eye, creating fluid wave to make it unfold, kind of like unscrolling a carpet. Eventually you get it unfolded and you keep it in position using a gas bubble. Gas bubble remains in the eye for about 5 to 7 days, and it acts as a tamponade, and that's all you need to make the transplant stick to the host cornea and start pumping the fluid out of the host cornea. And it's really remarkable how well this transplant works. I mean, even after like 2 weeks, the vision is much better. By 1 month, it's close to 20/20. Certainly by 3 months, a lot of patients are seeing 20/20, as long as they don't have glaucoma or macular degeneration that can affect the visual potential. Now, between the epithelium and the endothelium, you have the chunk of the cornea called stroma. Stroma is, takes up most of the cornea. It's affected by various diseases like corneal ulcer. That's a prime example that I see a lot. But you can also have other congenital diseases like keratoconus. So that's the disease that affects young patients. It's genetic, and the cornea becomes so weak that it fails to retain its spherical structure and it becomes a cone. Another disease that affects the corneal stroma is like a group of disease called corneal dystrophy, where it's usually autosomal dominant, and you've developed the corneal opacities in the stroma, usually in the center of the cornea, that can be quite visually significant. Really, the only way to remove the stroma, to replace the stroma, is with the full thickness corneal transplant called penetrating keratoplasty. This is an unfortunate patient that I took care of who had very bad fungal ulcer, and fungal ulcer usually doesn't respond to medical treatment. So I had to do a corneal transplant to debulk the fungal load. I mean, she did fine, but you see how it's much more invasive. You end up with 16 sutures. And these patients, you always have to warn them about blunt trauma, because when you are cutting your 8mm corneal button and you're replacing it and you're suturing it with 16 sutures, that junction that never completely heals. So I've seen a case, I took care of a patient who got hit by a football when he was playing with his 5-year-old, and then that wound opened up, he went blind. That's an open globe. I had a patient who was just simply unloading a suitcase, taking a suitcase out in the airplane, and then it fell on her face, hit her eye. It's an open globe. So I really try not to do penetrating keratoplasty if possible, but sometimes it's the only way to improve vision. Another common disease that affects the corneal stroma is actually ulcer from HSV or shingles. And just a little public, health announcement. I think that everyone should get Shingrix. If you end up with shingles in the eye, it causes a lot of pain. The cornea can melt. It can lead to scar. You may need a corneal transplant. So everyone should be recommended to get Shingrix when they become old enough for that. So post-operative management for corneal transplant is fairly straightforward. Mainly because you actually don't need a systemic immunosuppression. The eye unfortunately has an ocular immune privilege, meaning that the immune system is very different in the eye. There's blood-ocular barrier first of all. Second of all, there really is no lymphatic vessel draining the anterior chamber, vitreous cavity or subretinal space. And there are lots of immunosuppressive cytokines. So with these, once you do the transplant, all they need really is either topical, steroid or a topical cyclosporine eye drop. They do usually need to use it indefinitely, but it's much better than being on systemic treatment and just antibiotic eye drop for a week. And just before I move on to talk about LASIK, I just wanted to mention about eye banking in the United States. We are very fortunate in the United States because we have very generous population here. We procure more transplants, corneal tissues than we need. We actually export tissues to Asia and Europe. But also we have a very good national network eye banks that do a very good job of providing the best tissue possible. We often, I often get a choice of multiple tissues and I get to choose which one I like the best. And that's really a privilege that is a luxury that we get to enjoy because of the generous donors. And I'll end my talk by just talking a little bit about laser vision correction. I love laser vision correction because I can get patients who are blind without glasses to 20/20 in just a few days. The fundamental idea behind laser vision correction is that you're actually reshaping the cornea to get rid of the glasses prescription. Everything is done on the cornea on the outside of the eye. If your glasses prescription is minus, meaning you're myopic and you're nearsighted, you can get rid of the prescription by flattening the cornea, the central cornea. And so you actually use a laser to remove the central corneal tissue. But if you're hyperopic and you're farsighted, then you can steepen the central cornea by removing the peripheral corneal tissue. There are two main types of laser vision correction in the United States, LASIK and PRK. Both options get you to the same endpoint, but the procedure is quite different, recovery is quite different. With the LASIK, what you're doing is you are creating, using a femtosecond laser, you create a horizontal cut through the anterior stroma. You cut until you leave a little hinge, then you open the flap, which exposes the corneal stroma. Then you're reshaping the stroma using the excimer laser, which is different from femtosecond laser. PRK, on the other hand, you don't create a flap, you don't use femtosecond laser. You just mechanically debride the epithelium. So you're creating an abrasion to expose the stroma. And then you use the excimer laser to reshape the cornea. And you have to wait for that epithelium to regrow and remodel. So why is LASIK much more common in the United States? It's because the recovery is much faster. Even on day one, a lot of patients see 20/25. It takes anywhere between 1 to 2 or sometimes 4 weeks, but to get to 20/20. It's also pain-free, it's really minimal discomfort. PRK, on the other hand, takes time to get to 20/20. It can take as much as 6 months. The reason is you not only have to wait for the corneal abrasion to heal, but even after the corneal abrasion heals, epithelium is constantly remodeling. And so it can take up to 6 months for the corneal epithelium to remodel and for you to reach the stable vision. And it is also uncomfortable. Usually the discomfort starts about day 2 to day 3, and they usually need pain medication for that. But PRK is a little more forgiving. So with the LASIK, you have to have a healthy, thick cornea. But with the PRK, you can do it in thin corneas, in patients with irregular epithelium, the dry eyes, patients who have very deep orbit and tall nose. PRK is a better option because it's very hard to dock the femtosecond laser when you have a deep orbit. And patients who are at risk of blunt trauma, like those who play contact sports or military service, PRK could be a better option. So that's my preference, because that flap that you create with LASIK does not completely heal. And so there is always that risk. It's a very small risk, but there is that risk of flap dislocation in the setting of very hard blunt trauma. When patients come in for consultation, what you're really trying to make sure is, first, you need to make sure that their glasses prescription has been stable for at least a year. So that's ultimately what you're treating. You want to make sure that the corneal thickness and curvature are adequate. And there are no red flags in the medical history. Like, if you have uncontrolled diabetes, you're going to have poor healing. You're going to have, fluctuating glasses prescription. So not a good candidate. If you're on any retinoid product for acne, you need to be out of it for 6 months because that's a risk of worsening dry eyes. And if you're on sumatriptan or any of the triptans for migraine, also needs to be stopped because that can cause corneal abrasion after LASIK. And of course, you want to make sure cornea is clear. Eyelids are also normal. If you see a lot of blepharitis, that's the risk of infection. So that needs to be treated. And that's the same for also cataract surgery or any kind of eye surgery. The blepharitis, if you have a lot of crust along the lashes, there's usually some staph, colonization. So that really needs to be treated before any kind of intraocular surgery. And outcome is very good. More than 90% of the patients achieve 20/20. That's far better than cataract surgery outcome. And patients are very happy to be out of glasses or contacts and not worry about sleeping with contacts in and developing corneal ulcer. So I find this very gratifying. And that's it for me. Here's just a slide just about our practice. And if you have any questions, I'm happy to take them.
Well, thanks. Thanks for that, those views and that video. It was pretty cool. I hope this was able to answer some questions for us as primary care docs as we start to refer, and anyone who refers patients for the cataracts or corneal surgery. I found this to be really helpful. Dr. Cohen, we appreciate you coming out here and showing us the pictures. Once again, I just want to remind folks that we are going to take the summer off as we did last year. We'll be back in September, a good time to catch up on some of our talks that are up there and archived on the web at YouTube, as well as on our intranet. And I hope everyone has a really great summer, and we'll see you back in the fall. Thanks again. Bye.
Thank you so much.